So I'm just going to give a short introduction. For those of you who don't know Rosie, we're very pleased to have her here today. Rosie has qualified from Edinburgh in 2009 and undertook most of her obs and gynae specialist training in London. And during that time, she undertook her MD looking at the clinical utility of prediction models for adverse pregnancy outcomes. And this was undertaken at St George's University in London. And on return to Scotland as a SCREDS lecturer in ST6, Rosie completed her training and is now a senior clinical research fellow at the University of Edinburgh and also honorary consultant obstetrician at the Royal Infirmary of Edinburgh. From a research point of view, Rosie's currently an early postdoc fellow with the Chief Scientist Office, supporting development of an innovative digital birth cohort study, and is also leading the Small Baby Research Clinic in NHS Lothian, which facilitates a number of different studies investigating novel predictive variables for both stillbirth and other adverse pregnancy outcomes. And in addition to all of this, Rosie's also done a lot of work in Malawi, the Philippines and Uganda, and maintains those collaborations in global women's health going forward in Uganda, Nigeria, India and Pakistan. So lots going on. I know she's a very busy lady, so we're very pleased that she's taken a bit of time today to tell us about some of her work. So thank you, Rosie, and please do go ahead.
Thanks, Mairead. So I'm going to tell you a little bit where I am now. I think last time I spoke to you guys, I was just immediately finished my MD and I was talking to you about stillbirth prediction models. And I hope that what we're doing now has built on that somewhat. And I think is quite a nice marriage of research and clinical practice for us. So as Mairead said, we have recently set up a small baby clinic here in NHS Lothian, and that really met needs for both the university and for NHS. So in the university context, we'd recently been funded to do some discovery research looking into placental dysfunction and sort of novel biomarkers for stillbirth. And actually, because our management of people with placental dysfunction was pretty dispersed across fetal medicine and day assessment unit and triage, as I'm sure it is in a lot of places, it was hard for us to have a focused place to recruit people from. So for us to have a research clinic that brings these patients together was a benefit for our study. And so that's how we managed to get it funded and off the ground relatively quickly, which is nice. And, you know, the NHS processes are a lot slower than that. But from the NHS point of view, we knew that there was a problem with our care pathway and that the care was quite dispersed. So people were getting slightly different decision making, and our policy could have been better streamlined and we could have delivered better continuity for women who ultimately have a reasonably high risk pregnancy. We knew as well that because a lot of these patients did end up finding their way to fetal medicine at some point, that this particular clinical work took up about a third of all of our fetal medicine lists, which is something we thought could be usefully harmonised and taken out of the fetal medicine work stream. So still within the fetal medicine department, but in a separate dedicated clinic. And so that's where the small baby clinic came from. And I would argue that we definitely need a better service for small babies. This is our data from NHS Lothian. I think it's not particularly different in different parts of Scotland. And we still know that we are missing a huge number of small gestational age babies. This is the number of babies that are born after 40 weeks gestation when their birth weight is less than it should have been. And this would imply that these babies were not known to be small, were not offered early induction of labour. Of course, there will always be some women who prefer not to have induction of labour. And, you know, we might well as clinicians feel that with no other risk factors and a just marginally small baby, that's completely appropriate as well. But we shouldn't be seeing that over 50% of our small babies are being born after 40 weeks. That suggests that we do have a problem. And so we come to the Small Baby Research Clinic, which is every Wednesday, and I'm going straight there from here now. So this is me, our research midwife, our research fellow, and one of our patients who kindly consented to be part of this slideshow and had her small baby a few weeks after this. We see the patients ourselves, we scan them while we're seeing them, and they are managed by a team who makes consistent decisions. And if nothing else, I think that's a benefit to the women, and we get some really positive feedback from the clinic. And looking, we were up to 80 or 90 referrals now since March. So we're coming up for a whole year. And looking at the people that we're managing, most of them are coming because of reduced growth velocity. And I'm looking at how we can change our pathway to better reflect the data so that we're not causing over anxiety for people who just have a small, probably inter-observer variation in their growth velocity, but still managing to pick up the babies that do genuinely have a problem. And then we're looking at proper suspected growth restriction, or we're taking the stable preeclamptics as well, so we can monitor the growth of their babies because it falls into the same spectrum. And people who have obstetric history that puts them at very, very high risk of growth restriction. And our mode of delivery at the moment in the clinic isn't that different from the rest of the hospital, which I think, considering this is quite a high risk group of patients, is quite good. I'm reasonably happy with that. But the research problem that we have is that what we do in clinic, we scan them, we look at their risk factors, we look at what else is going on with their medically history, look at their blood pressure. We have all these tests, we can do CTGs, but we're still not very good at discriminating the genuinely small and struggling babies from the ones that are just small because they're short, and they're always going to be short, and that's absolutely fine. One of my small baby graduates is the baby of one of my registrars, who is a very tiny person herself. I saw them yesterday. The baby is still tiny, but she is completely healthy and tiny. She was always healthy and tiny. And a little bit of all of us collectively knowing too much. That baby was very, very heavily over monitored all the way through its pregnancy, and is fine now. Whereas, we have babies that we deliver and we think, oh, that baby really was struggling inside, and we're kind of lucky that this baby came out in good shape. And we lack the understanding of what's going on with the baby. And we focus, I think, a little bit too much on the baby, and we don't think about things that are around the baby. Firstly, the mother, and the mother lives in a world. The mother is out doing things. She's interacting with people. She's in the environment. She has her own health issues, and the things that she's exposed to, the things that she's doing, have an impact on the development of the baby. And so we know that looking at things beyond just her clinical risk factors, beyond just what we can gather from ultrasound, help us to improve the prediction of all sorts of pregnancy outcomes, preeclampsia and stillbirth as well. We have most information on some biomarkers. So, for example, biomarkers like PAPA and PLGF have been reasonably heavily investigated, particularly in the first trimester. And this is a table from a paper that we published a few years ago looking at the available clinical risk prediction models for stillbirth, and what gestation they were developed for use in. So first and second trimester models exclusively, no third trimester models, and what type of parameters they included. And what you can gather from this is that prediction is best when you integrate multiple different types of parameter. And that also what I can tell you is that none of these models even approach anything like clinical relevance. They are not useful to tell a woman at 10 weeks or 20 weeks that you have a 1 in 100 risk of stillbirth. You can't tell her when she's going to have that stillbirth. You can't tell her what intervention you can offer to reduce it. All you can tell is, congratulations, you're high risk. It's probably going to be fine, but it's maybe not. So these are not models that we can use. They don't answer a question that's important to women. They don't answer a question that's important to us as clinicians. But they can maybe give us some information about how we could move forwards to building better prediction tools and better tools for informing women. And so I think that message of we need to integrate different types of markers is really important. And I think the other thing I take from this is that we are building models based on data sets that are readily available. So those in the first and second trimester, we routinely collect the data. We have a lot of it. But the real problem that we have is third trimester risk assessment. We need to know what is going on with these babies in the third trimester, which babies can we safely leave alone and allow them to have whatever delivery they need to have, and which of the babies need to be fished out and rescued. And so probably the first and most promising answer to that comes from PLGF. And, I think this is something that's coming into our practice now, and it's almost moved beyond a research question. It's more a question of how do we best implement this. So this slide tells us at the top what our current model is looking for small babies, which is sort of the wholesale application of lots and lots of growth scans with all their limitations. And at the bottom, thinking about some of the ways that PLGF has been implemented around the world, and some of the ways where it is currently evidence-based in its implementation. So we know that PLGF, as part of first trimester screening in the FMF model, is good at picking up women at high risk of early onset preeclampsia, and by extension, women who are also at risk of other types of placenta dysfunction. And there is some evidence implementing that first trimester screening model, either with PLGF or PAPA, although PAPA has a slightly lower performance, and does reduce stillbirth. And there's been some debate as it might actually reduce stillbirth, particularly in the most high risk socioeconomic groups, which is really relevant, and would be really interesting to explore in Scotland when our socioeconomic mix is different, but we still see that sort of same inequity in outcomes. And then, of course, what PLGF is currently clinically approved for is the diagnosis and management of preeclampsia. And you'll know that the Scottish Government has now recommended that this is, and I'm sure we're all facing the same problem in our units. We've got no money to implement it, but we want to bring in the PLGF test, and we're thinking about the best ways that we can do that. And I think it is really important that we do that because it is useful for the diagnosis of preeclampsia, and there is evidence that it reduces our costs and it is better for women to know earlier that they've got that diagnosis. But I think we can also look to the future and see that this is a test that is going to have broader applicability in pregnancy, and we need to start thinking now, how do we set up our labs so that we can facilitate this? And in particular, what has just been reported, and there's a few more studies yet to come out, but there's a trial done in Spain, which reported at a conference last year and still hasn't published their data, looking at PLGF, and they were using the ratio, so the Roche-based platform test, for timing of delivery in babies that were known to be small for gestational age. So they were looking at babies between 36 and 37 weeks that had an estimated fetal weight, or AC, under the 10th centile, with positive end diastolic flow, so no other criteria for delivery before 37 weeks. So they were allowed to have raised PIs, but they had positive end diastolic flow. And in the control group, they managed them with Dopplers as standard. And so many of the babies who had sort of red flag signs, so they were under the 3rd centile, they had raised PIs, were delivered at 37 weeks, and the rest were delivered at 39 weeks. In the intervention group, they used the PLGF to determine who got delivered early. So they delivered everybody with an abnormal ratio at 37 weeks, and everybody with a normal ratio is delivered at 39 to 40 weeks. And what they found in that is completely intuitive. They almost eliminated maternal preeclampsia because, of course, if you deliver everybody who's got a normal abnormal PLGF, they won't have the opportunity to go on and get preeclampsia. They also found a reduction in PPH rates. It's interesting to think about whether or not that's a real outcome or that's just an artifact in the data. And importantly, from our point of view, they didn't show a difference in perinatal mortality, but they did show a prolongation of gestation in the intervention group, which would suggest that they were reducing the number of scheduled deliveries, induction of labour and elective sections for small for gestational age babies. So PLGF might be a little bit better at discriminating than Doppler alone. And also, importantly, there was no increase in adverse outcomes. So it was set up as a non-inferiority trial, and PLGF was not unsafe for the babies. So that was one setup in a Spanish trial. There are other studies looking at this in the UK setup. So the PLANE study, which is led out of Liverpool, is looking at PLGF in a similar group of patients. And there's another one which has gone completely out of my head now. But anyway, so those other PLGF studies, which we'll be reporting from a UK context very soon, I think we're going to see it coming in more and more to timing of delivery decisions. And so I think it's going to be part of our third trimester integrated assessment, which is why it's worth talking about it now. And we are collecting it on everybody that we see in a research context in the small baby clinic. And because we know it's going to be such an important part of those algorithms, we want to be able to correlate the other biomarkers that we're looking at with PLGF. So addressing that research question in the small baby clinic, we are collecting from there women who are happy to participate in research in a number of different programs that we're running. It's a real benefit for research clinics. They see the same team all the time with the researchers and the clinicians. We've got a good relationship with them. They're all very interested in how do we make our decisions about who gets delivered when, and how do we know what. So they really invested in the research question. So it's a very easy thing to say, would you mind signing up for this study? And we've got a range of studies. Born in Scotland is the easiest. This is the birth cohort study. All they have to do is give us permission to access their medical records, and then we can take their residual blood samples from the lab. We can take their clinical data from the electronic healthcare record, their ultrasound data, and they don't actually have to do anything else. But as part of Born in Scotland, we can then invite them as well. They give permission for contact later for secondary study. So we can go out to everyone who's born in Scotland and say, we're interested in your breastfeeding, or we're interested in, your baby's development, and invite them to participate in secondary studies. So it's already a really good resource, and going to get bigger and bigger and bigger, we hope. And hopefully we'll roll out across the whole of Scotland is the plan in the next year or two. So that's relatively low threat, and most people who walk through our doors end up in Born in Scotland because it's quite an easy one to get them to do, and we can actually stand over them while they scan the QR code and give consent for the study in clinic. The biobank is down there on the right. It's a very well-established resource in Edinburgh. So we've got bioresource. We've been collecting reproductive tissue for a number of years and can use it for a number of things. And if someone would like some reproductive tissue to study, it's open for secondary use requests. But we had been using that for taking the PLGF samples before we had the full study put through. So we can collect samples or placentas from anyone. And so it means that we are able to focus on or bring in people to the biobank where we think they're going to be able to help us answer a research question, which is nice. iTest I'm going to talk to you about in a lot of detail in a minute, because that's our biggest project at the moment, and I think it's quite interesting. I hope Mairead agrees. And then Simpreg is just starting, so we're going to have our first participant next week. Simpreg is the hardest sell, is the one that I'm not sure I would sign up for myself as a research participant. You see this woman is wearing these little wearable devices. In actual fact, the wearable device we have at the moment is a belt that goes around your chest. And we're going to ask pregnant women to wear these for the whole end of their pregnancy when they're already very uncomfortable. So they come into us and they have a whole bunch of cardiovascular assessment, non-invasive cardiovascular testing in our research facility, and serum samples, including PLGF, and all the uterine Dopplers, the fetal Dopplers, a full everything vascular is done. And then they go home wearing the wearables, and we're repeating the vascular measurements 2 weeks later as well. So we're interested in, can we correlate the findings from the wearables? Are there parameters, features that we can extract from the wearable devices that we can't get on a single visit cardiovascular assessment? Can we build a vascular model of this woman? And we're looking for both normal and abnormal pregnancies, to see, like, can we discriminate between normal and abnormal pregnancies based on the physiological signals we're picking up from these wearable devices? And, you know, there's a lot of stuff that you get with that continuous physiological data, like the response to exercise, like the variability of the heart rates, like the differences in sleep, that are really useful features that we think we all intuitively know must be associated with vascular response to pregnancy and with pregnancy health, but we can't measure in the clinic. And so this is a way of sending out measurements with the women and to see what features might be useful, and which of these could we potentially build into prediction in the future. So that is good. I will be very interested to see how our first participant gets on. But lastly, I'm going to talk to you a little bit about iTest, because it's where we are right now, and we are all about the eyes. This program is funded by In Utero, which is all about measurement and modelling during gestational development, and led by Professor Sarah Stock. And they're very interested in new biomarkers, and they're funding Simpreg as well. An obstetrician. I, like most obstetricians, spent a week in ophthalmology in medical school, and I once looked in the back of an eye, and I have since then never voluntarily looked in the back of an eye, apart from when I've had to, because I've been referring someone to neurology and they won't come unless I've looked in the back of the eye, although I know that whatever I see in the back of the eye is probably not clinically relevant in any way. But suddenly I've had to learn about the eye and remember that there are different layers at the back of the eye, and there's actually lots of tiny little blood vessels back there. And the human retina is actually a really interesting and uniquely accessible tissue of tiny macrovasculature. You can't actually get down to that level anywhere else in the body and non-invasively sample it in the same way that you can of the retina, because you can just shine a light through your eye and look at it. And so over the last decade, there's been increasing interest in the retina. And, you know, we have previously, as obstetricians, been interested in eyes. People have looked at ophthalmic artery Dopplers, because it's a reasonably easy and stable measure of the maternal vasculature. And there are some people now looking at just sort of the vessel patterns at the back of the eye as well. But what we're talking about in iTest is something a little bit different. And there are ways of measuring the vessel width, vascular complexity, that have been shown to be associated with really important outcomes like coronary artery disease, stroke, or chronic kidney disease. And actually, some of these changes occurring at that microvasculature level are present even before the traditional risk factors are. So individuals with higher risk factors for ischemic heart disease show a reduced branching pattern. And these associations can be independent of patients' age, cholesterol levels, and their BMI. And so that kind of pattern might actually be really a promising novel biomarker. And we can do this with just a simple camera, the kind that you have in your optometrist. And a lot of people who wear glasses will have to go and have this scans on a regular basis. And actually, there are features that you can extract from that data that might be really important in kidney health. And then, so some of our nephrology colleagues have recently published on this, is that you can actually use these markers to predict decline in renal function in patients who have chronic kidney disease. So we see all these renal patients, they come up every year or every 6 months, or however often it is, to have their EGFR monitored. You could actually do this by sending them to the optometrist, send them to have the photo taken of their eye. There's no blood test, there's no lab processing. It can be delivered close to their patient's house. You can then facilitate telemedicine review of that. You can pick out the people who are going to have a deterioration in their renal function by their eye test, which is really cool. And I think that all of us can immediately see that if there are differences in renal function, if there are differences in cardiac function, we are probably going to see differences in retinal patterns in pregnancy. And so that's what we've been doing in iTest, is just to ask that question: what are the differences? How can we pick them up? What are they associated with? And where can we start to extract some features that might be useful biomarkers for the future? And so we started with the very basic. So this is fundus photography. So this is what you see when you go to the optometrist, is just the normal picture of the eye. We can turn that into an SLO, or a scanning laser ophthalmoscopy picture. I've learned all these words in the last few months, and I'm still only just practicing. And then we can take it a step beyond that. So this is now a cross section through the back of the eye. Okay, so you can see the layers of the retina here. Okay, and this is optical coherence tomography. And so you can use this to measure the choroidal thickness. And you can also understand a little bit more about the choroidal vasculature underneath it. But what's really good for the choroidal vasculature is what you can reconstruct from the OCT, which is the OCT angiography. So this now is looking at the micro vessels in the back of the eye. So these are extremely tiny, but the branching patterns in those are really sensitive, and there's a lot of stuff that you can learn from that. So this is SLO. This is what the scanning laser ophthalmoscopy looks like. This is after the picture has been segmented, prepped. On the right here. So this is what it looks like when it's ready for analysis. And we're looking at the fractal patterns in the arteries. So here we've got an example of a healthy fractal pattern on the left and an unhealthy one on the right. And so this is a patient on the right who has experienced a myocardial infarction, who has poor vascular health. And you can see this sort of fewer vessels, fewer vessel mass is how we calculate that, and fewer branching, a less complex branching pattern as well. So the smaller vessels have just been pinched off at the end. And then we look at the OCT. So this is looking at that slice through the back of the eye. And this is what it looks like when we segment it. So you can get the different regions here, and you can separate out the vessels. So you can quantify the vascularity at the back of the eye, and you can quantify the thickness. And actually, this is an area that's really dynamically responsive, I have learned. So it's something that changes in minutes and hours. So some of these patterns with the vessel branching, are associated with long-term cardiovascular renal disorders, and completely as you would expect. And actually some of those are predictive of long-term neurodegenerative disease as well, which is really interesting. But the choroid thickness and the choroid vascularity can change over a matter of a very short period of time. And people have looked at this in sepsis patients in ITU as a mortality predictor. And because that's an example of a patient where we see a lot of fluid shifting, a lot of endothelial damage. And there's an association there with the choroidal thickness. And so we thought there might be in pregnancy. And unsurprisingly, there is. And I'll show you in a little bit. But it represents a little bit of that endothelial damage and health and leakage that is so important in a lot of pregnancy conditions. And our very clever, very shortly to be very deeply missed PhD student, Jamie, has developed this fully automated segmentation program called the Choroidalyzer, which in the left hand, this is the normal process of doing this choroid analysis, which is why it's not really been looked into very much. It's not that people didn't think it would be useful. It's just that it's so time consuming to segment and prep all of these pictures for analysis. You can't really run it through at scale, which is what you would need for our kind of application. So Jamie has now automated all of this, and we've got very nice code from him, which means that we can process that much quicker. And so this is becoming now something that you could do on the machine, so you could get a result straight away, and that would make it much, much more scalable. So the last sort of element of the imaging is the angiography. And so this is the OCT here. So this is looking at the slice through. And then when these little yellow spots, each of those is just a vessel. So they're so tiny, like this whole space is the back of your eye. These are tiny, tiny vessels. And then you can turn it into a picture like this. So we're really zoomed right in. And I normally make people ask, but I won't because you're all online and it gets a bit complicated. But the one in the middle, so can you see this one here? It has a black space in the middle, which is where it should be. The vessels shouldn't grow over that back part of the eye. And this is a normal branching pattern. So this one has less vessels, but they're growing over the central region. And this one has large twisty vessels. And so what we're looking at here is the difference between a control who's got a normal eye, a patient with diabetes and is experiencing a degree of vessel growth over the macula, and a patient with chronic kidney disease and probably chronic hypertension. And so the hypertension is what causes the tortuosity of those vessels. So distinct clinical phenotypes that you can pick up just from looking at the back of the eye. And this is just more of the OCTA methodology. So this is a big list of all the features that we can extract from it. Basically, each of these comes with at least 10 to 20 features that can be pulled out of it. And we're starting to try to get down to which of these features are important. So our pilot study is done. And this was a case controlled study to look at, to quantify what variability there was in some of these biomarkers and to compare women who had really markedly abnormal pregnancies with very normal pregnancies to really see, is there a signal there? Is there something that's worth investing in? So we recruited anyone who was over 34 weeks pregnant who had a very abnormal pregnancy, so either proper preeclampsia or proper fetal growth restriction, and women over 34 weeks with normal pregnancies. And so we had 28 women, I think 29 women. Some of these women are counted twice because there's no, I'm wrong. We've reported these results in several different ways, but this is all of them counted once. So everyone who is in this study had fetal growth restriction, and some of them also developed preeclampsia. But they're broadly similar in other respects. And this is our initial results from the case control study. So this is the scanning laser ophthalmoscopy, which is the black fractal branching pattern picture that is based on just that normal photograph of the back of the eye. And so in this relatively small group, what we can see is already quite a clear differentiation between the women who have the most severe phenotype, which is FGR with preeclampsia, and the women who have either normal pregnancies or just FGR without preeclampsia. And, you know, some of these FGR babies were delivered at 36, 37 weeks for FGR. We don't know if they would have gone on to get preeclampsia. It's part of what we need to explore, but we can see that there's a gradient there and that it fits with what we would expect. So we're seeing the fractal dimension and the vessel mass being lower in the preeclamptics. So that is more like the patient who had the ischemic heart disease earlier on. And similarly, this is now looking at the choroid, so the OCT, so looking at the vascularity at the back of the choroid and the thickness at the back of the choroid. And we're seeing increased thickness in the patients who have the most severe phenotype, so increased capillary leakage effectively, which again fits with what we biologically know about preeclampsia. And so we think that this does represent
Now, has it frozen for others?
Yes, it has, Myrid.
Okay, oh dear. I can only assume it's the internet issue again. So we'll just hold on for a minute or two. Maybe Rosie will go out and come in. I'll send an email. Hopefully she's able to come out and back, and we'll give it a second and see.
I'm back. I can hear you.
Oh, very good. Okay.
Yeah, no, I'm quite surprised that that lasted as long as it did. So that's good.
Yes. Well, that's fine.
Anyway, we're nearly done.
No,
I can let you
that's
guys start
lovely.
asking questions in a minute.
Thank you.
Let's see. Here we are. Okay, so that was our case control study. We're very happy with that. And so our next steps, we're moving into a cross-sectional design. And so we're aiming for a total of 200 per cohort. So we're going to go for a mixed risk group at 36 weeks. So all comers, anyone who's got anything at 36 weeks. And we're also prospectively recruiting people at either their 12 or 20 week scan to come along and have a retinal image done. And then we'll follow those same people up at 36 weeks. So we're now starting to look at the performance of this in an unselected group of women. And we're also interested in the longitudinal change over time. So we're seeing these differences at 36 weeks. Do they also exist at earlier gestations? Is there a delta between the 12 and the 20 weeks and the 20 and the 36 weeks? And so trying to understand, again, when would we have to do the testing for it to be clinically relevant? My feeling is that the 36-week test is going to be it, but I'm interested in that longitudinal change. And we do other data collection on these women for a variety of other studies in utero. So I've actually got, this is our latest data. So we've recruited, I think we're up to 90 women recruited now. And we've got complete data on about 60 of them. And so this is what we've got so far. And we still relatively poorly offer preeclamptics. So one of our things is to get more and more of the preeclamptics recruited out of DAU, I think. We're building up the sample all the time, and we're still seeing at the moment, and these are still early data, that we're seeing a difference between the preeclamptics and the controls. I think it's interesting as well, that we may not see much difference between the growth restricted babies and the normal babies, and I wonder if we're mainly picking up the maternal preeclampsia. And I think that's important. It's not what we were funded to look at. We were supposed to be looking for stillbirth markers, but if we find a good marker for maternal preeclampsia, that is still a good thing to find. And so I'll be interested to see how that plays out as we go on. And as we have more small babies, we're going to be able to separate them out a little bit more into the true FGR and to the what we actually retrospectively think were probably just SGA babies. And I think as well, we're going to add in our PLGF analysis to this, and we might be able to use the PLGF to discriminate amongst the small babies and look at the correlation between that. And then this is the latest in the SLO analysis. So we're still seeing that with the fractal dimensions, a significant difference to the preeclamptics, again, completely what we would predict. We're now moving as well into collecting the basic colour image of the fundus. So we weren't actually collecting that data to start off with, but we are thinking forwards to scalability and how many features can we extract from the basic image. So without having to add additional equipment into your local optometrist, like how much can we actually get from that and how much are they correlated? So we've done some correlation analysis on the different types of variables that we've got, and we're interested here in how easy can we make this. So we've gone really wide, and we've looked at every single feature that we can extract from each of these different types of modalities, and now we want to look at how well they're correlated to understand, okay, well, what's the simplest possible test that we could do that would give us a good predictive performance or that would show a strong association. And so this is what we're starting to come into now. So SLO is the easiest of all the tests to do, which is why we're really interested in can we infer things from its association with OCTA and OCT biomarkers. And what's interesting is that the SLO and the OCTA correlate, which to me makes logical sense. The SLO is looking at fractal branching of the relatively larger vessels at the back of the eye. The OCTA is looking at those teeny tiny ones in the choroid itself. And so they should correlate. They're both vascular measures. The choroid thickness, which we've said is a measure more of endothelial dysfunction rather than sort of necessarily the hypertensive profile, seems to be a little bit different. So it might be that OCT is still something that needs to be done, and we can't just replace it with a single color image. But it might be also that the color image is a good screening test for preeclampsia, but the OCT gives something else. So this is what we're starting to pick apart now, and it's still pretty early days, but this is quite interesting. So going forwards, we're looking at, in our data set, looking at the predictive power comparing predictive power between our existing practice, which is just using the NICE guidelines, which is poor. We know that is appalling, which is quite nice to have an appalling test to benchmark yourself against, because we must be better. So we can look at Born in Scotland, and we can look at our cohort, and we can say how well would we have picked up people at risk, and then we can start adding in some of the extra features that we've been extracting, and the PLGF and possibly uterine Doppler measures as well, and see, how good can we get the prediction, and what else do we need to add? What other kind of variables do we need? And what are we predicting? Are we mainly predicting preeclampsia? Are we predicting growth restriction? That kind of thing. Early modelling suggests that we will be able to predict preeclampsia. I'm very confident that we will. We just need to work out the variables, and then the next thing is, can we predict stillbirth and birth weight? And then to bring it all back home, at the end of the day, we do all of this because people are anxious and they want to know as much as they can about their pregnancy. And what's really nice about running the research like this is that we get to deliver clinical care alongside the work that we're doing. That helps motivate you through the very difficult conversations about the multiple different features of different kinds of vessel branching. And it also helps to be able to tell the patients, like, I'm really sorry that I don't know the answer to your question, but I can tell you we're doing the research that's going to find out. And I think everybody has found that really satisfying. I can't hear you.
Hello, can you hear me now?
Yes.
Sorry, I don't have any idea what happened there, but anyway, thanks very much. That was a great run through, and a nice update as well, actually, on what you know from sort of where you've moved on to from your MD, which is lovely. I must say I'm quite fascinated by the whole eye thing. It may be a bit ironic as it was the one area of medicine I knew I would never go into, but it is an interesting window on what's going on underneath it all. I'm just going to see if anyone has any questions. I think we've still got most of those who were here. I don't think we've lost anyone. Tara, go ahead.
Thank you. Thanks, Marion. Thanks, Rosie. That was a really excellent talk. I'm Tara Fairley. I'm one of Myron's obstetric colleagues in Aberdeen. Pleased to meet you. I have two questions, one very practical and one more esoteric. So the first question, the very practical one, is around the wearables, both for the eye study and the other one that I can't remember the name of. So obviously there are commercial wearables available that will do heart rate variability, pulse, respiratory rate, all these sorts of things. Obviously they're much more convenient and comfortable to wear than what you're suggesting is involved in your study. So I wondered if you'd given consideration to sort of trying to align with a commercial partner, someone like Whoop or something like that around this study. And then the other question is, absolutely fascinated by the retinal changes, and I'm wondering if you'd given any consideration to doing a non-pregnant scan, so perhaps in the postnatal period for women who've experienced FGR babies or preeclampsia, to see whether or not the retinal changes revert back to a more normal pattern, or whether this is something that might also be a predictor of longer term health. I know that out with pregnancy it would appear to be. Thanks very much.
No problem. Yes, we've to both of those. So we have looked at a bunch of different wearables. For this specific study, we're looking at 10 very intensively monitored women. And we do want some really high quality raw data because we're working with an analysis team in Swansea who do this all the time. And so they build vascular models out of, and they need the raw signal data. And as I get more into this, I'm learning that in terms of physiological monitors, there's the ones that are delivered to market to meet a need. And so that can be the ones that we have in hospital for our clinical use, or the ones that people use for their personal use. And so they will have a lot of signal processing built in and proprietary algorithms that present neat results to the end users, because that's what the end users need. But there's actually a lot of information that's lost in the signal along the way. And most of those commercial devices keep that raw data completely hidden. So it's really hard to access as a researcher. And then there's a lot of research devices that then make it very difficult to access the data and share it with the participants or the clinicians. And so you tend to either have research devices or commercial devices. More and more, I think commercial manufacturers are starting to understand the sort of value of working with researchers. And there's some good examples, some big Fitbit studies. Obviously, the Apple Watch studies are out there as well. And they tend to be the company choosing to collaborate with a researcher. We are interested in Born in Scotland in doing some physical activity work, and that you could do with Fitbit very, very easily, because that is something that you can draw off the phone in an API, and that's part of my fellowship work, which is, I think really interesting and exciting. You say to women, you're in this digital birth cohort, you don't need to do anything, but if you download this app to your phone and you happen to own a Fitbit or an Apple Watch, it's just going to feed us the step count. It'll feed us nothing else about you, but we'll get to know your physical activity, and then we actually can link that to your clinical data set, which is in Born in Scotland, and then we start to bring in variables into the birth cohort that we've never been able to collect off people before. So really cool and interesting, but it is different from what we're looking at with the very uncomfortable wearables. I have got so we've got an industry partner who design, they're trying to fit into that. I've just given you their sales blurb because they're trying to sell something that is research suitable but also clinically appropriate. And so they've given us some trial devices, so we're going to try those and see if they're more comfortable for our participants anyway. So yeah, I think it's a really interesting thing. And this idea of like bringing information in from where people are that we can't measure from the clinic, wearables are going to be really important. when I was pitching this fellowship idea, I had someone say to me, but you realize you're just going to like build a world in which every pregnant woman has to wear a pregnant woman wristwatch. And if she doesn't, she's a bad mother. And it's essentially just like, I'm like, okay, that's pretty scary. Maybe we should step away from the whole thing, which we haven't. But I think there are things to be thinking about in terms of the messages that we're giving to women. But it's a really useful research tool. And then the second question was about something that I've forgotten. I'm sorry.
That's okay, Rosie. It was about non-pregnant sort of interval retinal scans.
No, definitely really interested. I've presented this data twice to Anna Glazier so far, and every time she gets up and says, but what about the postnatal health of the women and the long-term cardiovascular risk? Because that's very important in preeclamptics. We've written up an application for it. We're just debating whether or not we want to put it in or we want to put something else different in. I'm sure that we will find differences, but how quickly they resolve is all part of the picture. So yes, it's definitely part of our plans.
Thanks you very much. Maybe a very just practical question, Rosie, about the PLGF that you're currently doing. Have you persuaded NHS Lothian to pay for it, or is it all research funded?
No, I mean, no, I don't know anyone who's managed to get it through a business case yet, and we've tried. And my hope is that if we're doing it on patients in clinic, that I can start to show a clinical use for it by if I'm providing clinical results. The problem is that I can only provide clinical results in the approved indication, which is diagnosis of preeclampsia. So I can't provide the clinical results to anyone else. But it means that I can say to people, you think someone's got preeclampsia, refer them to my clinic. I'll put them in the study. I'll give you a PLGF. And then we can start to build a pathway where we're using it. When we had it before, so we were part of Parrot 2, which was using PLGF testing, and we were very positive about it. Everybody wants to be able to use it. So it's not a lack of appetite from the clinicians, it is a funding thing, which everybody has problems with. One thing that is, I think, pretty cool, and if I get money for this, I'll be back to you, Marie, because I want to do it with you guys, but is point of care PLGF testing as well, which means you avoid all the lab setup costs. And there's, several devices available. The Quidel, which is the one that's commonly used and is already approved by the NHS in England, it does have the benchtop centrifuge. It's not super easy to use. So it's doable, and it's in practice in a lot of DAUs up and down England. Like, there's no reason we couldn't do that. We're moving on, and there's several devices coming onto market through research use only areas that are finger prick or blood straight onto a cassette in clinic, so you can get a result back in 20 minutes. And they're much more straightforward for non-clinicians to use, or for HCAs and things like that. So much more similar to an FFN, which that will be really good. Yeah.
Excellent. Yeah. And then the final question was just around the numbers you're having to recruit. I was wondering, for the SimPreg, is it relatively small numbers, or?
So 10 women is what we're going for SimPreg.
That's all. Okay. Yeah.
That's all.
Yeah.
Just
so hopefully,
hopefully we'll get there.
Good. Okay. I'll just check if anyone else has any other questions before we let Rosie get to her clinic. No, I don't think we do, but thank you very much. That was great, and we'll get you back again one of these days. Okay.
Cool.
Thanks very much.
Bye.
Bye-bye.
Thank you. Bye-bye.